I'm Mithun Suresh. I'm a physician with CentraCare in the newly formed medical school over in St. Cloud. This is the combat medicine technical session. Thanks to everyone for coming. A couple housekeeping items I want to get through, and then we'll get to our speakers. And so this is a 90-minute session, 10:30 to 12 o'clock. We have two speakers today. I've asked each speaker to go for somewhere between 20 and 30 minutes, so we should have plenty of time for questions after each presentation. At the end, we'll probably have even more time for questions. And then if we end early, that's okay too. I'll give you more time to sort of talk to the speakers in person. The other thing I also want to add, just for a housekeeping standpoint, this session is being recorded. So when it comes time for questions, there should be microphones that we'll have scattered around. If you don't mind, just before you ask your question, just wait for the microphone, just so you can speak into the microphone, and that way it's picked up by the folks that are recording so that people can hear it afterwards. And so last thing I just sort of want to add before we get started with our speakers. So I mentioned we have two speakers. There was actually a third speaker going to be here, Dr. Greg Beelman, who unfortunately at the last minute was not able to make it today. But I do want to just take a minute, and if any of you know Dr. Beelman, you know he's outstanding. He is a world-class scientist, a phenomenal clinician. But on a personal level, he's been a mentor for me for many, many years. And frankly, I think a big reason why I have the honor of organizing this is that several years ago, I had the opportunity to spend some time at the Institute of Surgical Research and Brooke Army Medical Center. As we're probably going to see, both of our presenters have pretty strong connections to those institutions. And the reason I had that wonderful opportunity was because of the kindness of folks like Dr. Beelman. And so I know he's feels very bad about not being able to be here, but again, just on a personal level, I do want to take this opportunity to thank him for all of his outstanding patient care, his military service, but also personally to me and many of my colleagues, all the years of mentorship that he's provided to all of us. So with that, let's get to our speakers. So our first speaker is a colleague of mine actually in St. Cloud, Dr. Patrick Osborne. So Dr. Osborne is a professor of orthopedic surgery, and he's the director of the orthopedics department at the M Health and CentraCare Orthopedics Department in St. Cloud. Now, he is a graduate of the Air Force Academy and retired from the Air Force in 2022. And after that, spent some time in San Antonio and then came up here to take his current role in St. Cloud. He's an expert in orthopedic trauma, foot and ankle injuries, compartment syndrome, and sustainment of wartime skills. And you know, I could talk about his resume. He sent me a copy of that, but honestly, if I do that both with Dr. Osborne and Dr. Rasmussen, I'd be talking until tomorrow. I mean, they're that accomplished. But there's a couple things I do want to highlight. When he was in the military, he was the director of the orthopedic surgery residency program at San Antonio Military Medical Center, which is the largest orthopedics program in the DoD. And just before he retired from the military, he was the deputy commander for surgical services, or in other words, the surgeon in chief at Brooke Army Medical Center, which is the largest level 1 trauma center in the DoD. And so he'll be talking about Call of Duty simulation ops. Dr. Osborne, welcome to the DNB conference. Thank you for spending some time with us. I'm looking forward to your talk.
Thank you, Mithun. I really appreciate the invite, and I'm very glad to be here today. I'm sorry if I'm a little bit off. I got on my phone last night in last-minute preparation looking for surgical simulation apps, and there's a surprising amount. And so I played this one for way too long, trying to see what it would do. Actually, it wasn't that long because I disagreed with what it was doing, and it was just a little bit creepy, and it was starting to give me a little bit of a Leisure Suit Larry vibe, so I signed off and left. As Mithun mentioned, I did a lot of different things at Brooke Army Medical Center, the only Level 1 trauma center in DoD, which we're very proud of. But I was involved in clinical research and other things, compartment syndrome, as he mentioned. My real passion was education and really focusing on readiness and readiness sustainment of surgical skills, in particular critical care skills. Because at Brooke Army, as a Level 1 trauma center, seeing civilian patients, in my opinion, we were always really the stalwart in maintaining those critical skills, not only for individuals or small teams, but for an entire system. And we had over 7,000 trauma admissions a year, very high volume in addition to any wartime trauma that we saw, and I'm very proud of what we did for the San Antonio and South Texas region. So I hemmed and hawed a lot about what this talk was going to be on, and I felt that looking at simulation and the need for simulation as an augment to sustaining readiness skills in the military was the way to go. So skill sustainment has been written and talked about a lot. It's a critical military need. A lot of us know about the Walker dip, which is in a post-war period. There's a decrease on the importance of wartime trauma and learning, decrease in research dollars, and overall a decrease in the support of sustainment and building those skills. As recently as 2019, looking at the readiness scores, readiness skills of surgeons, looking at knowledge and skills and abilities. About 10% of military surgeons met readiness criteria. That was it. And this was compounded by the fact that their surgical volume went down by about 25% over a 5-year period. And when you get ready to deploy, and then you come back from deployment, you may come back a trauma expert, dealing in amputations and horrific injuries, but leading into that deployment, on average, 6 to 8 weeks of decreased volume, and then an equal or longer period to build your surgical volume back up after that deployment period. So there's a huge stretch where you're not maximizing your ability to sustain those skills. This is further compounded by the fact that the military system, especially in smaller bases, smaller hospitals, up to 90% of the major cases, open bellies, vascular surgeries, major orthopedic surgeries, 90% of those cases are referred out to the TRICARE network in the local civilian area. So that puts a further hurt on the volume that surgeons are getting. So the clinical readiness program was something that was started up a while ago and looking at the knowledge, skills, and abilities to maintain readiness. And in 2023, they took an initial look at how people were scoring, and the majority of surgeons were really deficient in both knowledge and skills as measured by this program. So technical skills is certainly part of it, and this is some research I have published previously, and this is looking at the orthopedic trauma procedures within DoD. This focused on a narrower scope than the KSA, the Knowledge, Skills, Abilities program, and really focused on fracture care, debridements, compartment releases, things that were closely tied to wartime trauma, not arthroscopy, not some of these other procedures. And with that narrower scope, we found that really there was, amongst the top 10 military hospitals, there wasn't a whole lot of difference unless you saw civilian trauma patients like we did at Brooke Army. And even you can see here, the vast majority, close to over 2/3 of our volume was from civilian patients. So no military treatment facility is going to be able to have sufficient volume of true critical wartime skills without the ability to branch out, whether it's to see civilian patients in the local community or other options. Another study that we did was looking at amputations and specifically over a 10-year period at the beginning of OIF and OEF in Afghanistan and Iraq. There's about 1,200 amputations that were done, or 1,200 patients that had an amputation. Looking from 2017 to 19, less than 5% of military surgeons had actually done an amputation for trauma. Now, that excluded vascular issues and things like that, but that did not bump that issue much more. And trauma amputations are different. You have different tissue to work with, and it's a much more timely decision-making process that has to be made. We found that there is a fairly limited amount of cases, as I showed before, but the diversity of the cases was really very limited, except for in many cases at Brooke Army Medical Center where we saw the civilian patients. So we really found that that was really irreplaceable, but again, not everybody can, not every military facility can take that on. So this, again, is something that has been written about. There's difficulty with sustainment and retention of skilled personnel as a result because of career dissatisfaction. So in pushing Brooke Army as the hot spot for readiness sustainment, we looked at what happened with the patients that we had. And we took civilian patients, and based on ISS, we kind of matched them with, our average patient was an ISS of around 8, multiple extremity injuries, and then we did have the unfortunate occurrences where with fracking incidents, we would have things that really approximated an IED blast. And so beyond physicians, beyond residents, looking at PAs, nurse extenders, medics, techs, and chaplains, lab personnel, radiology techs, you name it. And in the first 10 days of these patient submissions, these are the patient encounters that were logged in the medical record. And that really, again, cannot be matched by anything else that was out there at the time. And so on the top is the number of personnel that were involved, and then on the bottom is the number of those encounters logged in the EMR. So really, and to this date, not everything that I've seen and read and updates, there's really only one facility that provides that breadth of training and sustainment to the entire system, the entire hospital. And we'll go through some of the other avenues that the military has taken, but this is really a systemic way to address readiness and skill sustainment. So the initiatives that the military have taken are in many different forms. There's initial training looking at tech and professional school, in large part done at Fort Sam Houston and San Antonio, graduate medical education in different military treatment facilities, and then looking at sustainment. In garrison care, what cases are done at the hospital on base, military-civilian partnerships, C-STARS in St. Louis, in Cincinnati, and shock trauma in Maryland. The Army has a different program, AMCET3, where they put small teams at civilian facilities to gain that trauma experience. And then there's off-duty employment, which is highly controversial, but moonlighting and going out and working at a more trauma-heavy facility is certainly a way that people were able to build those knowledge and skills and ability. But again, that's not universally available, but it has been shown that that makes a significant bump in what people are exposed to. And then there's a lot of just-in-time training. Right before deployment, going to Miami Ryder Medical Center to do the Army Trauma Training course. There's a SMART course for non-physicians as well, and then a combat surgery skills course, other formal courses before deployment to hopefully brush people up on some emergency procedures in deployed medicine. So the questions remain on how effective this is. What is your audience? Are you looking at physicians? Are you looking at surgeons? Are you looking at nurses or techs? What are the resources that are available, especially in garrison on base? Not every place has the ability to have a simulation lab, have a cadaver lab, and these courses are offered at very limited places. What skill set are you trying to build? And how does that team work together? And then looking at the outcomes of that training all are things that really have not been answered or are difficult questions. And then the concerns are, what is the capacity to teach people for the military-civilian partnerships? What's the capacity to take on more military teams? Does that start interfering with the surgeons and the team at the host site? Does it interfere with GME? Consistency is a big concern on how much the military teams are exposed. There have been some studies that show that the exposure has been pretty equivalent to the civilian staff there, but that varies site to site. And the data that looks at that has not been uniform to this point. So what we're getting is getting better from a data standpoint, but we really don't know across the board what kind of training we're getting, what the value of the training is, and then controversies, again, mainly with off-duty employment being one of the key ones. So there's a wide disparity in requirements, the experience of the personnel going to these courses or in these places, and the resources of the host site or the training site. and different skill levels. Somebody right out of residency getting ready to deploy is different than somebody who's been in the service for 10 years and is deployed 3 times. So you have to be adaptive. You have to have different options for learning and tailoring that to people. So old school, simple things, models and cadavers. The left is a cut suit, which is gaining more and more popularity, but it's very expensive. There are issues with tissue planes and kind of the haptics, the feel of it. And then cadavers are cadavers. Now, perfusion cadavers certainly help with that, but again, the tissue is not the same. And so the fidelity of it is a little bit less than we might hope. Live animal, very useful. It reacts to you, doesn't react based on what somebody tells it to do. It reacts physiologically more like a patient might, but that's very controversial. And more animal research is looking to be phased out. There are several billboards in San Antonio looking to eradicate that. Virtual reality, again, this is an up-and-coming technology. It has certain benefit, especially with technical skills and branching out more into team skills. But again, this is expensive. It is very user-dependent, and it can be glitchy. And then there's role-playing, and then tabletop exercises. Again, more for team training, more for bigger system training. So fidelity, you'll read a lot about fidelity when you look at simulation, and really this is how close to reality is this simulation. So physical component of that, does it feel right in my hand? You'll read a lot about haptics. How does it react? Do you get feedback from what you're working on or touching? And again, some models, live animal, a great example of something that has great haptics, but a cadaver and some of the virtual reality components do not. Conceptual, is this how a patient would react? And I regularly get my butt kicked by my son on Call of Duty, and how he comes up and knifes me in the foot when I just think I shot him, center of mass. I don't get that. That does not help with simulation being effective. It breaks that reality contract that we'll talk about in a little bit. And then, is this how I would feel? Am I feeling stressed? Am I feeling this is bogus? Do I feel more immersed in this because the fidelity of this is making me feel like I'm actually there? Engagement might even be more important, and this is how we perceive that this is real. So behavioral is a big component of this, and you have to have that fiction contract where I'm suspending reality. I'm going to treat this as if it was real, and this takes leadership, and it takes self-discipline. Emotional, so you go in with preconceptions on what this training might be, but to build that engagement and higher fidelity models, that simulation is going to make you feel things, and it should make you feel the right things. But it really has to, and they talk about emotional preparation with some of these. And then you have to have that cognitive engagement. Is this getting me what I think I need? Is the goal, are the intended goals of this training actually being met? And so engagement is really critical. You cannot have this guy who, especially as a leader of a team training, who knows that this isn't real, isn't going to treat it as real no matter what you do, and really isn't going to play along. So it's really a two-way street when you get into simulation. Individual skills are one area where simulation can be very effective, both in skills acquisition and in sustaining those skills. It's safe. You really can't hurt much other than yourself. It builds confidence, especially in young learners or people who have been out of practice in those particular skills. It allows you to identify knowledge and skill gaps and expand your situational awareness. Has been shown, especially with higher fidelity things, that it allows for prioritization of tasks to be improved, to improve the time to make critical decisions, and to react to physiologic changes a little bit quicker. And again, is it preparing you emotionally for what you might encounter? And again, that goes to more high fidelity and higher engagement models. Low and high fidelity models work very effectively for this, whether it's sewing up a pig's foot, putting on an external fixator like on the top, or just using one of these virtual reality endoscopy models. High fidelity has been shown to improve technical skills a little bit better, but without daily practice, deliberate learning, whatever you want to call it, those skills decline. So it can't just be a spot check with simulation. Oh, we're good to go. And that's really the crux of the issue with sustainment. And the other thing is it has to be built as part of a structured curriculum. If you just let somebody go in and wail away and do whatever they want, you may develop bad habits, and some of you may not catch them if they're not supervised. And if they don't have a curriculum to follow, then they don't really have that part of the cognitive engagement of what am I getting from this? It almost becomes like a video game or something else. So it really needs to be part of a structured curriculum and well supervised. And that takes time to train those people that can provide that supervision and instruction. Team training goes all the way from small unit training to a hospital-based and even a broader healthcare system-based options for simulation. This has been shown to improve better recognition of roles and responsibilities. You know, if you go to advanced cardiac life support or even basic life support, this is the person doing compressions, this is the recorder, this is the team lead. It really helps people work out who is in charge, what they are in charge of, and gets the team going with a better definition of those roles and responsibilities. It allows that leader to work on efficient division of labor. And it expands that situational awareness for the entire group. Again, just like with the individual skills, it can help with quicker critical decisions. Do we intubate? Do we get advanced imaging? Do we go to the operating room? Those kinds of things. And then, again, prioritization of tasks and better communication amongst the team. Testing and practicing communication is certainly one of the more difficult things in a team treating a patient. So all these go into better communication, but it gives you an avenue to practice that communication. Again, emotional preparation, both for the simulation, but it also is the simulation prepping you for the emotions you might feel when you're doing these tasks. That is a key component. And it's really been also found to improve the leader's effectiveness in driving all of these and that team coming together. Crisis management is something that can be applied across the board, whether it's technical skills for the individual, a small team, a bigger team. Certainly in the flying world that I was in briefly, before I went to med school, you know, you had your emergency procedures. They were bold-faced. There were 3 or 4 steps. Here's what you do when you eject. Here's what you do when an engine stops working. All these things that are supposed to be rote memory, muscle memory to save an aircraft, whatever it might be. It's the same kind of thing. And this is where, for medical simulation, it goes beyond that bold-face, but in a safe environment, it gets you the opportunity to practice the worst of the worst. So again, it focuses on leadership for those team skills, communication, especially under a high stress environment or situation, preparedness. Is my team prepared? Do we have the materials to take care of this patient? Looking at a hospital or a bigger system, do we have masks? Do we have saline? Do we have blood? Is the CT scan working or not? All those things in preparing for a bigger crisis is important. And then workload distribution. Again, prioritization and then defining roles and responsibilities from a small team all the way up to a major health system. How are we going to do triage? How are we as a small team going to triage the issues that this one patient has? How is a hospital going to deal with triage of a mass casualty event? And then disruptions, whether it's electrical, supply, some part of your team is not able to perform, media issues. All these things can be tested in crisis management scenarios, again, that can range from the individual doing VR or a cadaver that's perfused or live animal, all the way up to more of a tabletop or even a large-scale exercise for a larger healthcare system. The focusing on crisis management definitely builds confidence. It improves communication because you have to work through not just a normal situation, but something that's very high stress, more confusion, more things that are pulling away from your situational awareness. And it really allows you to identify those deficiencies, so your preparation is better. The issue with a lot of these, especially the larger scale things, is that you do have to sacrifice realism. You know, you have somebody moulaged up and, you know, you see them kind of walking in and out. Okay, it's worth it because we got the triage work on that. We stressed our people for a brief time. We looked at resources. So that's a reasonable trade-off when looking at broader things. So one crisis management exercise that we went through was in November of 2019. And we had a large-scale exercise doing a mass casualty, mass shooting incident that covered multiple hospitals in San Antonio. But then a couple days later, we had a tabletop exercise, and cue your Twilight Zone music here, looking at a novel virus pandemic. So there's no simulation that could have prepared us for what happened going into 2020. And if you look on the right side of that, you're getting into Valentine's Day weekend in San Antonio. We had just come off a major COVID spike. And everybody was taking a little bit of a deep breath. And then the headlines came out. Snow and ice coming to South Texas. And here's the projection, and this is actually what the temperatures were. So sub-freezing for about 9 days in a row. Texas is not prepared for this. Growing up in Rochester, frozen pipes weren't a thing unless you did something dumb. In Texas, frozen pipes are a real thing. These are FDCs, fire department couplings. The front two look like they fit together pretty well. The third one, I don't know where that goes. So we learned early on as things froze that to get water to the hospitals, we were using fire trucks to go and load up the pipes in the hospital so they had clean water. Well, we learned in short order that there were different fire department couplings. Either, you know, the fire truck did not have the one that fit the city or the hospital, or the hospital had one that nobody had ever seen. So we were scrambling to get these fire department couplings. We were able to get some healthcare facilities the water, but then the pipes froze, and this is the lobby of the Children's Hospital in San Antonio. And you can see the water streaming down on the left, and it was crazy. It was truly, as they said down there, Snowmageddon. And then, this is taken from my backyard. Despite the cold, and because of the lack of water, and the power grid, and all these issues, fires did start. And this took out a huge apartment, or one part of an apartment complex, and it was complicated by the fact that the fire hydrants froze. And so what they did is they took from the pool of the apartment complex, and they went to the golf resort across the way, and the trucks pumped the water out of the pools and applied it here. But this building, this part of the complex, was a total loss. So nothing that we did really could prepare us for this. But again, our focus on crisis management did make it where we could innovate. But at the end, we're all like, now that I have these new terms, where's the conceptual fidelity? What am I supposed to learn from this? Or, you know, how is this real? And then the cognitive engagement of, what am I supposed to get from this? Because I'm inundated. So there is a level where things might be too much, but this is the kind of thing that effective simulation and crisis management, simulation in particular, can prepare you for. So the challenge I put out to people that are much smarter than I am on, you know, my simulation experience is really limited to video games, but you have to have something that's valid and reliable. Are you getting reliable and consistent results, or what you expect to get, and are you testing what you should be testing? It has to be adaptable, not only to the learner and their skill level and their schedule. Scheduling is a big part, especially of team training, that's difficult, but is it adaptable to the site? Do they have the resources? Is it portable? What makes it most usable and most broadly applicable? You have to have a structured curriculum. This takes time. This takes training. This is a huge investment, but it is a key aspect of not allowing for unstructured, unsupervised practice that leads to bad habits or incorrect procedures or practices. And you have to have feedback. You have to have good assessments so you know that you're making improvements, and you have to have feedback to those students. Sometimes that feedback can be instantaneous with haptics and other things that are in somebody's hands, but you have to have somebody with experience that can go over a video of it or transcript of it, just observing it to give that feedback for true improvement. And then cost is a huge part of this. Estimates have been that it's at least $100,000 depending on the simulation system that you use to start up, and it can be $10,000 and far more for sustainment of that, for software upgrades, for mechanical or electronic issues, you name it. So it's not cheap. And so it's definitely investment there. So technology comes in where we can improve fidelity. Does it immerse the learner in that scenario? Does it give good feedback? Is it giving that level of fidelity where people feel like they're there? And building that engagement is probably more important. Can they suspend that reality? Can they leap in and take that, suspend the fiction or take the fiction contract and say, yep, I'm going to treat this as real? Does it stress them? Does it make them feel what they're supposed to feel? And do they feel like they're getting what they should out of that? So it's got to be multimodal. It's got to be complementary to all those other things that I talked about, the military-civilian partnerships. All those are excellent programs. They've done a lot for sustainment of skills, but not everybody can go through them. Not everybody can be at Brooke Army Medical Center all the time. So you have to complement what the military is doing now, and that's where technology can really help in pushing out those modalities across the force. And then continuing to build that bridge from traditional sawbones, live animal, cadaver. Virtual reality is becoming more and more, and then getting into mixed reality or extended reality where you have things that integrate with the virtual reality headset and give you that feel, give you that feedback, and act like normal tissue and react like normal tissue. And all the studies that you look at on this, all the good studies, are all meta-analyses, looking at thousands of papers and coning it down to 20 to 50 papers. Good research into what simulation does, and then getting it to translate to better patient outcomes is really the holy grail, in my opinion. And that is the ultimate in cognitive engagement, where I'm learning what I can apply to make patients better. It does work. My Jedi skills have improved. The Meta and the Vader Immortal app I love, and I think I can take on a young Jedi better. So the technology is there, because if I can learn to do that, then I have no doubt that simulation can take on that greater role to teach us how to take care of better patients. Thank you.
Wonderful. Thank you, Dr. Osborne. That was fantastic. Since we only have two speakers, I think we have plenty of time for questions, so maybe we'll just go ahead and take questions now for Dr. Osborne. So questions for Dr. Osborne. And again, we have a microphone here, so if you have one, you can just hold off until we get you the microphone. Oh, we've got two over there. Perfect. So maybe I'll start with one. Oz. One of the things you didn't talk about was AI, and I think AI is probably the hottest topic within technology right now, certainly in healthcare too. It's gaining a lot of traction. Can you talk a little bit about how you think AI can be used to augment the simulation space?
Yeah, so there's more and more being written on AI, and where that the push for AI is going into that extended reality. And some of that is with using 3D printing, AI applications for that, but also they talk about segmentation and performance of skills that AI can help learn and guide further training. So that mixed or extended reality uses the model is for 3D printed things of, whether it's a body cavity, organs, you name it. And for that to integrate with a virtual reality headset. And then using that AI to improve the haptics, to improve the feedback. And segmentation is looking at, well, what does this layer act like? What does this part act like? What does this part act like? And how that adjusts as you go through a simulation. But the other part that AI still is struggling with, and where a lot of the push is, okay, somebody does this, what do I do with that in the simulation? And that's where AI and increased computing capacity will help. That mesh between something that you're holding and working with, as opposed to true virtual reality where it's just on the headset, you might have joysticks or what have you, but tying that to something that you can actually feel and have that better fidelity because you have a model right there, that's really where AI is being used at this point.
Wonderful. Other questions at all for Dr. Osborne?
All right. Thanks very much.
I have a question or
Yes,
comment,
sir.
maybe. For those in the audience who wonder how, or thinking about how to get connected with the military's training programs and sort of integrate the innovation that's in the room and at this conference with military programs, is it your experience or recommendation that they find contemporaries and colleagues, sort of like-minded scientists or innovators who are either in San Antonio at Brooke Army, the Institute of Surgical Research, the Uniformed Services University, Walter Reed? I mean, how is it that folks, at a civilian university who are, bright and innovating, having days like this, how can they best connect with and help the military innovate in this space?
Well, here, it's too bad Dr. Bielman isn't here, but there's a great opportunity with a grant from the Uniformed Services University that Dr. Bielman's heading up for the Translational Center for Resuscitative Trauma Care. And that is lives here at the university. There's multiple research opportunities within that. So locally, that's a great opportunity right there. And the amount of work that Dr. Bielman and that team is going to do will be impressive because, as I mentioned, there's a lot of military-civilian partnerships for clinical care. And certainly, I don't want to knock them, but they are fairly limited in what they can provide because there's only so many people that they can take on. But looking at research opportunities, things like the Translational Center here, there's been more and more cross-institution research. The Major Extremity Trauma Consortium had 50 plus trauma centers across the states doing multiple studies, looking at infection, looking at healing of bones. It was the largest orthopedic trauma research effort with a lot of DoD funds and other funds that continues to publish, looking at all sorts of things related to orthopedic trauma. Excuse me. And even, again, here locally, the North Star Trauma Network out of Regions and Health Partners is not funded by DoD, but those obviously apply to not only our local patients, but those orthopedic trauma lessons do apply downrange. And those are all efforts that really fight that walker dip. And it's a real danger. We see it. I mean, history repeats itself no matter how much we write about it. So Dr. Bielman's effort up here, and Todd, you can probably speak better to what is going on at Mayo. But there are certainly opportunities. If you look for them, there's certainly a big opportunity here in the coming years with Dr. Bielman's work, and all that will advance and maintain those skills that we need for wartime care.
Wonderful. I thought I saw a hand. Yeah, there's a hand in back. Couple hands in back. Good.
Thank you. Bala Haridas from Texas A&M. So fully transparent, we collaborate with Julie Rizzo at the BAMC. I had a question. I'm glad I attended your session. So when you talk about the training gaps across the 4 roles of care, where are the biggest, gaps right now? Is it role 1, role 2, role 3, role 4, or do you see a pattern that's emerged
I
in the
think-
last 10 years?
I think it's probably roll 2 and roll 3. The amputation study that we did, that 1,200 patients that had amputations was specifically looking at roll 2 and roll 3 patients. There's been a lot of work done on the golden hour. I think, and so initial resuscitation and those kinds of issues will always remain a concern. But to me, that follow-on care, whether it's at roll 2 or roll 3, is really key because it's not just technical skills. Doing an amputation is not technically hard, right? To do one well, that's a roll 4 capability, really, to finalize the residual limb, to have something that's ready for a prosthesis. At roll 2 and roll 3, it's decision-making. It's what I've always termed the trauma mindset. Can you make the decision? Are you comfortable with making that decision in amputating some kid's leg or his other leg at the same time? That's hard, and that only comes through experience. And I've seen disasters, and Todd, I'm sure you've seen them as well, is that people are uncomfortable with those decisions, and then they get to roll 4, and those patients are really sick because they're carrying a dead leg, a ton of dead muscle. Their kidneys are dying. They're physiologically worsening because somebody wasn't comfortable making that decision to amputate, which is hard. There's no doubt about it. But building that decision-making skill, building that confidence and competence to make the hard decision at the roll 2 and roll 3 in particular, that really is, to me, is the major gap. The technical skills, you can teach most anybody to do those.
Just before we get to the next question, do folks know what roll 1, roll 2, roll 3 care is? Do you mind just explaining that just for the audience?
Roll 1 is basically that field station where a casualty might go to initially. And then a roll 2 is more, not a hardened structure, but kind of a field hospital kind of thing, or a field clinic. It's very small team managing that, but that's where a lot of these casualties will go after being stabilized at the roll 1. And then roll 3, probably the best example is Bagram, the hospital, Craig Theater Hospital at Bagram Air Base in the day, which was a hardened facility. We had, 2 or 3 ORs, I forget exactly. We had an inpatient unit, things like that. And then roll 4 is Lon Stuhlerbeck stateside. So that roll 2 and roll 3 is in the heat of the battle, certainly the roll 2, and that's where a lot of critical decisions are made.
Wonderful. There's a question in back.
Yeah, great presentation. I'm very interested in the work you've been doing. I can tell you've done a lot. I've been doing some work with building training simulations and applications for educating on various cardiac diseases like congenital heart defects, where some of these cases only arise in hospitals once every 10 years. So educating the future of the pediatric cardiologist to be able to diagnose and treat these cases effectively is something that these simulations can really help with. I guess one thing that we've kind of been coming to issues with is these applications seem to have great effect to students. They say that it really helps them become more comfortable with the procedures because they're able to visualize it. They know what to expect. One thing that we kind of are having difficulties with is getting objective data to prove that they are developing skills from using these tools that are effective for them, in their jobs and in the future. I guess, what ways do you see would be the best way to evaluate how much skill or value the learner is getting from these tools? Yeah.
So I mentioned that curriculum, that structured curriculum beforehand. Learning objectives, the simple thing of that. What are we actually going to look at? There's a lot of things you could look at, but what are we focusing on with this? They talk about progressive training with simulation. All right, you do the simple things, and then based on time, based on the number of hand movements, if you're grasping for something on an endoscopic simulator, how quickly can you grab it? Did you have misses? Things like that before you step on to the next level. It's very difficult. You really do. And, somebody may get lucky. That's why repetitive and progressive is important. So you hopefully take out some of that luck. And then, I think the best simulation curricula have a knowledge assessment as part of it. And yeah, again, technical skills can oftentimes be easy or simple, but do you know how to apply those? And that should be part of whatever, it goes back again to that cognitive engagement of, am I involved in this? Am I engaged in this because I know I'm getting something from it? And that really can only be done with a knowledge assessment and the application of what you learn in the simulation. So yeah, it's a very tough kind of thing. And I think that's where virtual reality can help, because you can track eye movements. That's where AI can help, and some of this extended reality on, how much a hand is moving, how many, missed throws of the suture or what have you. That's another holy grail on really assessing what it is. And, the opinions of people and that qualitative assessment of what they thought about the training is important, but it doesn't give you that objective data. So I think that will continue to grow as the technology improves and you can really watch what people are doing. And some of the emotional prep ones looked at heart rate and these kinds of things to tell if people were really stressed. And so it goes beyond just what somebody's doing with their hands to how their body is physiologically reacting. Are they truly engaged? And then the knowledge piece is really what wraps it up.
Wonderful. Any other questions?
Thanks very much.
Awesome.
Thanks.
All right. For our next speaker, pleased to introduce once again Dr. Todd Rasmussen. And so Dr. Rasmussen is from the Mayo Clinic, and he joined Mayo in 2021. There he is a professor of surgery. He's a vascular surgeon. He's also the director of the Gonda Vascular Center down there. Prior to joining Mayo, he was in the Air Force for many years. And once again, similar to Dr. Osborne, if I go through his resume, I'll be talking until tomorrow. Both of them are just that accomplished. But his area of expertise within vascular surgery is in a variety of areas: vascular trauma, endovascular catheter therapies, and one of the things he'll be talking about today, acellular vascular technologies for vascular injury repair. He's had a number of leadership roles within the DoD. Just a couple of them I want to highlight. One at the ISR, which has come up a few times now, where he was the deputy commander. Then he's also been the director of the Combat Casualty Care Research Program. And then I believe just before leaving the Air Force, he was the Associate Dean for Research at the Uniformed Services University. So once again, Dr. Rasmussen, thanks again for coming up, and really looking forward to your talk this year. So thank you.
Well, thank you very much, Mithun, for the introduction and the opportunity to be here. I hope in the next 20 or 25 minutes to give you some resources to inform you in your innovative efforts here at the university and in the city. So be ready with some, if there's resources that'll come, some references that I hope you find useful. Some of them are very current and some of them are a little bit dated, but I hope you find them useful. And then the second thing is to give some examples of innovations that have happened that are relevant for combat casualty care. That I picked 2 or 3 that I've been directly involved in. And the innovations that I'll go through they're just case studies, but I present them as case studies, and hopefully you can sort of think about your own innovation and ways in which you're innovating and how the experience from these case studies might apply to your work. So again, I appreciate the opportunity to address you this morning. These are some of these are all of my disclosures here. The main one I think to point out is that Humacyte is a company that makes a human acellular vessel I'll speak about. They provide Mayo Clinic with research funding to support one of our studies, but not any to me personally. So this is a current resource that I'll provide to you. I hope this link, QR code, is accurate or still active, I guess I should say. Greg Beelman, we've mentioned. I do miss him here this morning, and I hope he's able to rejoin the mission here real soon. Greg and I wrote this about a week or 2 after Secretary of Defense Hegseth gave his congressional testimony and then was nominated and confirmed. And in this op-ed that was published in the Star Trib, we highlighted and played off of Secretary Hegseth's focus on warfighter lethality, and a focus, the new Pentagon's focus on warfighter lethality. What does that mean? And Greg and I took the perspective that warfighter lethality relates to the human system. We talk about weapon systems, communication systems, all sorts of systems in the military's casualty care or all DoD-wide, but the human system has often been cited as the most important system, even more important than weapons, communication systems in the military's armamentarium. So in the context of Secretary Hegseth's comments on warfighter lethality, we pose in this op-ed, we're all in, and Minnesota's all in. This room, the university's all in to optimize the human system. And certainly the other context is the multi-domain operations, or MDO, that is in our national defense and national security strategies, multi-domain operations. One of the most important domains is the human domain. There's air, land, sea, cyber, space. Those are all the domains of MDO, but the other is human domain. And I think Minnesota, as we pose in this, is well positioned to do that. Medical innovation provides the opportunity to optimize, prepare, and then when needed, repair and restore the human weapon system. And that's sort of what you're sort of all here for, I think, is to find ways to optimize, prepare, and when needed, repair and restore the human weapon system. And so we offered that in the Star Trib as an op-ed, and I think is sort of a way to reset our thinking about how this state in particular can aid in that important mission. So from my own personal perspective, I know Oz spoke to this, and being on the same speaking platform as him, it's a pleasure. He and I have spent a lot of time probably in both of these theater wars over the past decade or two. Really, this is my background for the innovations I'll speak about. And the prolonged duration of combat, which was the longest in U.S. history, and the only prolonged period of combat to be conducted by an all-volunteer force. There was no draft, which I think is another, we could give a talk about that as well, but it's important for the public to kind of remember that. Because of the prolonged duration for 14 or 15 years, the volume of injured really compelled the military to make much larger and more consistent investments in medical research. Oz spoke to the Walker Dip, or how the country's attention can be distracted in an interwar period, and I think that's a real phenomenon. But the innovations I'll speak about here were spurred by this. This is another resource for you that, it's interesting, I wrote this with Tanisha Fazal. I don't know if any of you know her. She's at the University of Minnesota. She's on faculty here. We wrote this, we probably prepared it in 2017 and published it in War on the Rocks in 2018. It's more relevant today than ever. Some things don't age well. I've written plenty of those articles. This one really ages well. I think it talks about how long the U.S. military's golden hour can last. And we wrote in here, to address the challenges in the future of combat casualty care, the U.S. will need to make system-wide changes and transform in the following areas: medical technologies, medical training, and I actually think there's sort of an ethics part of this article about expectations that the military and the public may have to have in the setting of multi-domain operations like happening in Ukraine. Who can survive? And which can we even have a limb salvage rate of 80 or 90%? Or is that just an inaccurate expectation in some of the future near-peer conflicts that have been discussed and are potential? So, we're here today to talk about medical technologies, need for new approaches to reduce, in the context of what I'm going to speak about, death from bleeding and shock. This is a photograph. I put this back in just this weekend. I showed this at a grand rounds that I gave 2 weeks ago, and I gave my grand rounds on the 16th of April. And I realized when I showed this photo, it's 20 years ago. These old photographs are time-stamped. This is taken with a camera, and this was 20 years ago at Balad Air Base in Iraq, and it shows sort of the austere tent composition of this being a Role 3, Echelon 3 hospital, where we would operate on patients who came back after being injured. Oz mentioned the Air Force Theater Hospital in Bagram. This was probably in 2010, this photograph was taken. And it's really from this bedside of patients. We talk about bedside to bench, bench to bedside. This is the bedside for casualty care in a lot of ways. And Oz and I, and maybe others in the room, had the opportunity to be immersed at this bedside, more probably than we really wanted. And that's where a lot of these innovations come from. I won't spend a lot of time on some of these publications. This is a critical one. This is referred to as the Death on the Battlefield paper. That was really led by the Army's Brian Eastridge. This was published when I was at the Institute of Surgical Research. I hope that QR code is active. Sometimes they aren't, but I would refer you to this. This was a once in a generation report on why our casualties died, like our KIAs. And it was a study of almost 4,600 KIAs, meaning these were U.S. service members who died before getting care. So this group painstakingly went to Dover, where the Armed Forces Medical System is, the coroner, and went through almost 4,500 autopsies to look at why the cause of death in almost 4,600 KIA. I mean, painstaking is probably an understatement. And I knew Brian. I was part of this project. I did not go to Dover, but Lauren Blackburn, you see his name there. He was the commander when he's my boss when I was there. What they found, unsurprisingly, was that 3/4 of the KIAs were not survivable. They were deemed to have lethal head, cardiac injury, total body disruption. They were never going to survive. But what sort of the nugget of gold in this study was they identified that 1 in 4 almost of the KIAs had actually injury patterns that were potentially preventable. They could have survived. They didn't have a lethal cardiac wound. They didn't have a lethal head wound. They didn't have body disruption from blast. And what they found was that most of those patients died from bleeding. They just bled to death. And that was sort of game on to say, well, if we could stop bleeding and have better ways to stop bleeding, we could mitigate that 24% potentially preventable death rate. So the studies like this was the main one that allowed us to hone, remember, it's not just device, it's the system too. We had to hone medevac, pre-hospital care, resuscitation, surgical care, and this was the military's ethos is leave no one behind. And I think that this type of study personified that ethos. We did a specific study looking at vascular injury. This is one of the later studies that really quantified that almost 18% of combat injured service personnel had a vascular injury, almost 1 in 5. This is also, these sorts of data, epidemiologic studies give you the targets to aim at. You want to know what to aim your innovation at, this sort of thing helps us with that. Interestingly, extremity vascular injury is the most common. I guess that's not interesting. That was predictable. But what was interesting was that some form of vascular repair was attempted at almost 2/3 of these injuries. So that our trauma system, our combat casualty care system, was enabling us to try to fix these vascular injuries in austere conditions. So again, another target to aim innovation at. So those were sort of the data generating studies that showed gaps in care, which then drove the research and development and then product delivery. So we needed innovation to improve the control of shock and bleeding. Most of that is what we call non-tourniquetable or non-compressible hemorrhage in the torso. You can't put a tourniquet on a grade 4 spleen injury, for example. So we needed innovation for shock. And then we needed, because we knew that repair was possible in 2/3 of vascular injuries, we needed innovations to expand the armamentarium for limb salvage in extremity injuries with major vascular injury. And the focus here was on not just saving the limb, but having quality or functional limb salvage. It wasn't just statistical limb salvage. We high-five because we could save the leg, but if the leg doesn't work well, all the muscles and nerves are dead. That's not quality or functional limb salvage. So that's sort of the data that helped us with this. So I'll talk about 2 or 3 innovations. Again, these are just case studies. Many of these, a couple of these innovations are through, in a way, they're through FDA clearance and all that. But I think the case studies, I hope, are useful as you innovate and think of ways that you can get your ideas and your innovations through the sort of the product cycle to the bedside. One is resuscitative endovascular balloon occlusion of the aorta, or REBOA. That was an innovation that was developed because we had a need to control hemorrhagic shock from torsovascular injury. The other two relate to extremity vascular injury, the human acellular vessel, the temporary vascular shunt, and I'll show pictures of those. And those were, again, developed or with the thought of increasing or building our armamentarium to fix vascular injury downrange. So REBOA, this is a REBOA catheter, this is an endovascular device, this is the temporary vascular shunt, and then this is the human acellular vessel, which is effectively a blood vessel grown in an organ chamber. Decellularized, and I'll talk a little bit about it, but these are the three kind of case studies in innovation I'll go through. Each of these innovations has features that kind of affect their development, their regulatory approval, and as I said, many of them are through regulatory approval now, but they're not into clinical adoption. So now they're in that sort of final phase of getting to the bedside and being used in patients. So I think those are the three innovations I'll mention to you. So endovascular technologies, those are inside the blood vessels. Those are innovations like stents. You may have had a stent in a family member, a coronary stent. Those are placed inside the blood vessels. We put a portal of entry in the femoral artery, and most often, and then we're able to work inside of the blood vessel to deliver a stent, or in this case, a balloon. And these wars were the first in which endovascular technologies were available. The large-scale, combat operations in Vietnam, there was no endovascular technology. And you think about it, there was a 4 or 5 decade gap. And so now the wars in Afghanistan and Iraq they occurred during a time in which endovascular technologies were available. These are some examples. Believe it or not, I don't know if this is a plug. You can deliver this into a 1 to 2 centimeter diameter blood vessel from the inside of the vessel and plug it. So if somebody has a hemorrhaging spleen, instead of cutting them open and taking the spleen out, you can put this plug in the splenic artery and stop the bleeding. It's an endovascular technology. This is the balloon, occlusion in the descending thoracic aorta in a patient who's on the verge of cardiovascular collapse, PEA, for example, from hemorrhage. You can put a balloon in and augment coronary perfusion to the brain, give some afterload, and that balloon can serve as a bridge until blood can be given and bleeding formally stopped. And then these are examples of a stent graft. This can be placed inside of a broken blood vessel as a bridge. And then this is an example of a coil, which is similar to the plug, which can be put inside of a blood vessel to stop it from bleeding. So these are all endovascular technologies. This is our group here in Iraq in 2005 or 6. As I said, two of the 4 people pictured here are endovascular surgeons, myself and Mike Roller. And we were able to then take very rudimentary endovascular skills into the theater of war, even in 2005 and 2006. Now, we were using Oz's C-arm that he was trying to use to diagnose bone injury, and we are improvising to try to use rudimentary C-arm or radiographic imaging to deliver these endovascular devices. But because of our training and sort of this war occurring in a modern endovascular era, these techniques were obvious to us to at least try and then try to develop. One of those was resuscitative endovascular balloon occlusion of the aorta, or REBOA. So this just sort of depicts in yellow the remote, from a remote location, entering the vasculature, the arterial circulation, and placing a compliant balloon in the aorta to augment afterload. And if there's bleeding in the abdomen, this balloon can be placed in the thoracic aorta. When it's inflated, it increases pressure above the balloon and stops bleeding below the balloon. It's pretty simple. The pressure above the balloon can give some life-sustaining pressure to the coronary arteries, right? That's what the 2 things. You gotta keep the brain alive and the cardiac myocytes alive, and that can stem cardiovascular collapse. So this is REBOA, again, trying to augment pressure above and below. We wrote a paper while at the ISR that sort of described REBOA and the concept of REBOA and the different zones of aortic occlusion. This really recharged or reset this idea of balloon occlusion for trauma and shock. This was a rare thing. This Oz and Mithun may remember Dr. Basil Pruitt, who was the editor-in-chief of the Journal of Trauma at the time, a famous burn surgeon and an important mentor of mine. He was a Journal of Trauma editor, and he finished his role or his era in December of 2011. He'd been the editor-in-chief for 10 years. And in the months before, he said, look, I see this endovascular technology coming down the pike. Can you write an article describing REBOA? And because we need to know about it. We meaning the Journal of Trauma community, the readership. And it was a rare thing. I submitted on October 31st, and he accepted it the next day, and it was published in December, so the following month, which was his last month as editor-in-chief. And it was, I bring that up because he, even at his, sort of the end of his career and tenure, recognized innovation, and he was calling for this to like stir debate and to stir innovation, and I always had admired him for that. So this is some of our earliest drawings that led to that paper. I cut the date off. That was probably in September of 2009 or 10. And I show these because I know there's young innovators in the audience, and you think it's silly that, you write things. Do you really write things on a napkin? And you do. You all have lab books. You keep track of your reagents, and you record your experiments. This is examples of that. These are some of our earliest drawings of a REBOA catheter that we made. That was in October of 2009. So those things really can make their way into, into prototype development and preclinical testing, and then to the bedside with time. But you've got to write down your ideas. They say the best time to plant an apple, when you need an apple, the best time to plant an apple tree was 15 years ago. The second best time is now. And so write down your ideas, because the clock doesn't stop and wait for you. So write down your ideas. It's probably too late for me and Oz, probably not you, Mithun, but write down your ideas, because it takes time for these things to germinate. That was 15 years ago. Yeah, 16 years ago. So that patent, so those drawings went to a patent, then a prototype. Those prototypes, we referred to those initial ones as Home Depot versions because they were pretty crude, but a prototype allows one to do applied testing in a preclinical model, either a benchtop model of, in this case, a benchtop model of tubing, basically, or in porcine or preclinical animal models. So that's sort of prototyping and applied studies, then sort of a licensing to commercialization at some point in order to get the Home Depot model to something that it can actually be seriously considered for first in human study. And by the FDA, one needs to partner. And I think for me, and that was partnering with engineers, because that prototype was with engineers, but before engineers came, that's all we had. Was that. So you got to partner, and partner, for us, that meant engineering. Often you need to partner with a bench scientist to develop a drug, right? A new drug or a biologic. For us, this was a device. We needed biomedical engineers. We did obviously we had to license the IP from the inventors to the university. And then once that happens, then we needed to garner investment, because investment is needed. The NIH is not going to fund, unlikely to fund, this level of translation from a prototype into a commercially viable product. So often that requires private investment or investment from universities or other private entities. So that all came to then, here we are, that's 2017, this endovascular balloon occlusion. This is it's what now is an old REBOA catheter, was approved in 2017, and we published this article kind of describing it in JAMA Surgery. The original old REBOA catheter was used in over 200 hospitals. It's had uses around the world. It's just sort of clunky, though. It was a first, Mithun and I was talking about device iteration. It's, the first device is never the end device. It's never the final one. You learn from the first one. You can iterate the device development and improve on it. But this was the first REBOA device. We pursued, in this case, a 510K pathway. So part of the reason this was done quickly was because it was developed at the end of the wars. There was some urgency to bring something to the end of the Afghanistan war, at least, to try to stop hemorrhage. And so we chose a 510K pathway, and that's how this catheter came. Now, there's a new partial Reboa device. I won't go into this too much, but this just speaks to device iteration. If you follow the timeline of these publications, this device has a pop-off valve that facilitates its safe inflation of this balloon, for example. And in 2020, 2021, this new prototype was tested in preclinical animal models, in this case in Ann Arbor at the University of Michigan, and shown to be sort of safe and effective. And then this new Reboa catheter was approved by the FDA and has its CE mark in 22 and last year for the CE mark. So this is the new titratable partial aortic occlusion balloon, and you see now its first in human studies are being published in 23 and 24. So there is currently a prospective study of this new Reboa catheter, that was called the P-Reboa Pro catheter, that's supported by the military. This is a publication in Military Medicine at the end of last year that describes this prompt study, and it's looking to refine Reboa technology so that it's more usable, it's safer, more effective, and such. This study will look at the impact of early femoral artery access, proactive use of this, the efficacy of partial aortic occlusion instead of complete aortic occlusion, and then ultimately, hopefully, its impact on hemorrhage-related mortality. So if we move to temporary vascular shunts, this is the second innovation. This is a photograph from a case in Iraq. This shows two temporary vascular shunts in the femoral, one in the femoral artery and one in the femoral vein at the thigh of an injured service member. There's flow in both of those. One has got, the one being grasped has a Doppler signal with arterial flow. The one below it is in the femoral vein, and it's got venous flow in it. These devices are inserted across an injured vessel where there is no flow to bridge flow downrange, distal to the injury. So in this case, these shunts were placed quickly at a roll 2 or forward unit to restore flow into the leg and flow out of the leg from the venous injury, and sort of act as a bridge. When these devices or when these patients were evacuated closer to us, then we would cut these shunts out and then we would do formal vascular repair. These are examples. This is the left knee. There's a popliteal artery injury here to the artery and the vein. You see the temporary vascular shunts, two, one in the artery and one in the vein here. This is the left knee. So, a bullet or a fragment went through here and injured these two. So these shunts are useful. Now, at the beginning of the war, we were using shunts that were not designed for trauma. This is an example, another example of one in here. This case was designed for me because they told me where to operate. They put a big arrow and said, operate here. So my residents give me a hard time when I show them this. They said, well, Dr. Rasmussen, you knew exactly where to operate because the roll 2 physicians had put a picture or drawn of where the shunt was. This shows, there's a shunt in here, and instead of a tourniquet having been in place for 4 or 6 hours, they placed a shunt, and this flow, this leg had flow in it. And this allowed us to have a nice viable leg. It's had a fasciotomy incision here. And then we were able at a roll 3, a more equipped location, to take these shunts out, do a vascular repair, and then try to save that leg. So we've documented our experience with the use of temporary vascular shunts. This is an old paper in 2006 where we saw that the use of these shunts was very important for us in the management of large volume vascular injuries. And these are some examples. This is also timestamped for my 2005 deployment. These are some examples of some older shunts that were never designed for trauma. So these were designed for my vascular practice at Mayo Clinic, not for use by general and trauma surgeons downrange. And so we began to iterate a new temporary vascular shunt, we said, or innovate. And so this is our patent declaration on a new military-specific trauma vascular shunt. Again, write it down, disclose your idea, and then get working on it. And this is an example of that. And The temporary vascular shunt now, this work has now been licensed with Mayo from the Air Force, and we're beginning first in human studies, hopefully next year, with this new temporary vascular shunt. The last innovation is now conduits, vascular conduits. So the question is, when you take out these shunts, what are you going to fix that blood vessel with? So there's a gap there where there's vessel missing. And so we typically will take the patient's own saphenous vein and use that. That's a nice biologic, and we can use the saphenous vein to bridge that gap. We can use Gore-Tex, biologic grade Gore-Tex grafts. Those are also very useful. The challenge with those two conduits, at least the vein conduit, it may not be available. If the vein got hit with fragments in an injury like this, there may be no saphenous vein. And the limitations of synthetic conduits are they don't become incorporated into we don't incorporate them as well because they're not biologic, it's Gore-Tex. So we embarked on an effort with smart innovators at a spin-off company of Duke, scientists there who developed what we refer to as the human acellular vessel. This shows the complexity of these types of injuries. This is an injury from Afghanistan 2010 or 12, and you can see that this is an awful injury here. This is a arrow pointing to a superficial artery injury that has a shunt in it. And there's flow going through that shunt, perfusing this leg, which has a fasciotomy here. They put an X-fix on it. And you may think, well, this is awful. You can never save that right leg. But I would say there's an X here that has an arterial Doppler signal in it. This is actually a fasciotomy when there is a tib-fib fracture, but that's not it looks awful, but skilled surgeons like Oz can kind of put this back together. The question is, can we maintain flow, and how are we going to fix that vascular injury? And even though it's a long shot, this patient needs it because they've lost the left leg, right? So these sorts of complex situations that really kind of can easily sort of overwhelm one's sort of approach, you have to sort of step through these. And in this case, we need a conduit. If we use Gore-Tex here, it'll get infected. It'll never become incorporated. And this patient has no saphenous vein because the other leg's gone, and obviously there's no saphenous vein to use as conduit on the right leg. So this is the last innovation I'll mention. This is the human acellular vessel. This is a human vascular smooth muscle cell sourced biologic where human vascular smooth muscle cells are seated on a biodegradable polyethylene glycol lattice here. And these are the cells. This is then put in a bioreactor, pulsed and grown in an organ chamber effectively. For the scientists, I call it a bioreactor, an organ chamber basically. They're growing cells, and as the cells proliferate in this nutrient bioreactor, the polyethylene glycol dissolves, and then one is left with basically a grown blood vessel. And as a last step, then the cellular components are rinsed out of this to make it immunologically silent or biologically silent so that it doesn't elicit immune response. And one is left then with this basically extracellular matrix collagen elastin conduit, and it's biologic. And the idea here is if this is implanted, then the host or the recipient, your cells could then incorporate and smooth muscle cells or even endothelial cells. So this is the human acellular vessel. We have used this surgical innovation section in JAMA surgery to describe this. This is the bioreactor that it's actually shipped in. It's a 6 millimeter diameter by 40 centimeter long conduit. It has an inner dowel or inner component that needs to be brought out. This shows us sewing two of them together to attain length. Sometimes you need more than 40 centimeters of conduit. We've written an article about the implications of the human acellular vessel in the Journal of Trauma. In some ways, it's an ideal conduit. It's off the shelf. It needs to be refrigerated, but not frozen. You can't freeze it. It's not cryopreserved. So you can just take it off the shelf. You don't have to find saphenous vein. It is a biologic that may be resistant to infection. It may be better than taking another off-the-shelf product like Gore-Tex. It might be better. And it may become incorporated by the host cells. So you can plant it in a patient. So it comes in a predictable diameter, and its handling properties, it's pretty easy to sew in. So this is an off-the-shelf biologic that is coming through research development and has recently been FDA approved in December for use in humans. We implanted this in Walter Reed under the FDA Expanded Access Program or Compassionate Use Program in 2019, had the first human implants there. This shows the product here again. We're sewing two together. This shows it laid out on a patient's left lower extremity. The groin is up here, left femoral artery, and here's the left knee, and we're gonna use this as a conduit to bypass severe peripheral arterial disease in this patient's left lower extremity. Mayo Clinic, we started a FDA-supported IND study that started with 5 implants in 2021, and we've now implanted 40 total. Our IND study allowed us to do 35 patients. We implanted our last one of those in January of this year. We use about once a month there at Mayo over the last 4 years under very strict IND FDA-controlled conditions. This is a patient who had bypass from the left iliac artery to the femoral artery and then down to this popliteal artery, and we used the human acellular vessel in part of this. So we used Dacron, and this is not a combat injury, this is a case from Mayo Clinic. We used Dacron or polyester as the conduit here, and then the human acellular vessel. This shows the Dacron graft sewn to the iliac artery. Dacron is a very good conduit as well. This is the human acellular vessel sewn to the Dacron, and then the human acellular vessel sewn to the popliteal artery just above the knee. As an example case, not used in this case in trauma, but just our IND experience at Mayo. Another sort of example of sewing this conduit into arteries at Mayo. We've published our experience with this at the IND study at Mayo Clinic and Mayo Clinic Proceedings last year. Looks like it was a year ago. That has been very important part of that development is now taking it into IND and FDA study of the human acellular vessel. So this is my last slide, I believe. This is an article that Don Coleman, who's a chief of vascular surgery at Duke, and I wrote in the Annals of Surgery last year talking about the ethos of leave no one behind. And I just refer you to that because I think a lot of the innovations you are aiming for and working with the DoD to improve the human domain, the human weapon system, if you will, strike to this sort of leave no one behind ethos. So, you know, in conclusion, the longest war in U.S. history resulted in restructuring of DoD medical investments in research. It resulted in collaborations between civilian universities, industry, scientists, and engineers, all here today. And I, from my perspective, and these cases, vascular injury and hemorrhage control are a leading cause of shock, potentially preventable mortality and limb loss, and emphasizing sort of the need for these agile, off-the-shelf solutions. So I'll end there. Thank you again for the opportunity to speak to this topic and take questions if there are any. Thank you, Mithun.
Yeah, once again, Dr. Rasmussen, that was wonderful.
Thank you.
Questions for Dr. Rasmussen?
I have a question. So you've spoken about the different tiers from the first presentation, and I was wondering, when you were trying to develop these devices to help with hemorrhagic stroke, or not stroke, but hemorrhagic bleeding in general, were you trying to counteract like one specific stage, or were you kind of just looking at it as an overall view?
Really good question, insightful question. If you look back to the Death on the Battlefield study, the Eastridge study that I referenced, the majority of deaths are pre-hospital. You know, those patients, once we could get them into our OR, you know, their survival was 95%. But if you really looked at all mortality, those 4,600 service members, they almost all died, 90% died pre-hospital. So I think a lot of the innovations, certainly the Reboa catheter and other innovations, are aimed at, you know, role 1 or role 2. There's gaps there to try to mitigate that potentially preventable mortality. I mean, obviously the human acellular vessel, that's aimed at a more echelon 3 or 4, you know, mature hospital where you can take the time to sew those in. So the human acellular vessels aimed more at a established hospital or echelon 3, but the Reboa catheter was aimed at pre-hospital, mitigating pre-hospital mortality.
Thank you.
Yeah, sure, great question. All right,
I've got a question for you.
sure.
The human acellular vessel, is that being used in any current military conflicts?
Yeah, that's a great question. It has been used in the war in Ukraine on a very limited basis. There's publications about that. And so it's very, it's still very early in its use. It's mature in its development and it's mature in its regulatory application, but clinical use widespread is very limited. But it has been used in 10 or 20 cases. I think that the Humacyte, the company that had that, worked with the FDA and obviously the Ministry of Defense for European countries and NATO to get that product into the Ukrainian theater of war. And it has been used, and they published on it on a limited basis, 10 cases, 15 cases like that. All right,
Other questions for Dr. Rasmussen?
it's good. You guys are hungry too. All right, well, I'll just end by saying thanks for all you do. I'm glad you're here, and it's great to be with Oz. And I think to end, how do you connect here? Connect with Dr. Bielman, Mithun. I mean, there's ways that your innovations can connect with DoD and DoD labs. It's not always obvious, but there's a route there, and you just need to sort of find it. And also read, the op-ed sort of speaks to that a little bit too. So, okay, thank you very much.
All right. Thank you, Juan. Thanks, everyone.